Hello and welcome. I'm thrilled to have you join us today for what promises to be a timely and impactful discussion hosted by the Center for Health Technology and Innovation. My name is Pat Dunn and I'll be moderating this webinar. Our focus today is on a topic that touches the core of healthcare delivery, physician burnout, and how technology can play a meaningful role in addressing it. As the demands on clinicians continue to grow, so does the need for thoughtful, innovative solutions that can ease the administrative burden, streamline workflows, and restore balance in the lives of our healthcare professionals. We're honored to be joined by a panel of remarkable experts who are not only leaders in health technology and innovation, but also passionate advocates for physician well-being. Please join me in welcoming Brianna Wong, Principal Manager of Clinical Product Strategy at Microsoft and adjunct faculty at the University of Denver, Dr. Chris O'Connor, CEO of First History, and Dr. Georg Van Heusen, co-founder and CEO of Tenaceo. Together, they'll share real-world insights, emerging research, and practical strategies that demonstrate how technology can be a true ally and not a burden in the clinical environment. We encourage you to engage throughout today's session by asking questions, share your questions, your experiences, your ideas, because it's through collaboration and conversation that we can begin to reimagine a healthcare system where clinicians not only survive, but thrive. So let's start by meeting our panel. And why don't we start with Brianna? Could you introduce yourself, please?
Yep, just a quick introduction. Again, I'm Brianna Wong. I am adjunct faculty at the University of Denver, where I cover topics at the intersection of healthcare and technology. And then I'm also the principal manager of clinical product strategy at Microsoft. And today I'm sharing really kind of my personal thoughts on a lot of this.
Great. And Georg?
I'm Georg Van Heusen, medical doctor by training. I worked in cardiology, then consulting and big pharma. And from there, I started my own company back in 2019 called Tenaceo, where our mission is to improve outcomes for patients with cardiovascular diseases by providing physicians with risk predictions and individual treatment recommendations to make their life easier and to avoid premature death, stroke, and bleeding events.
And Chris?
I'm Chris O'Connor. I'm the CEO of First History. I'm an internal medicine critical care physician. I still practice a little bit, so I experience everything that we speak. Serial tech entrepreneur. I founded a company, Think Research, back in the day, which was a collaborative network around building and developing treatment plans for hospitalized patients or order sets. Grew it to projects in 8 countries, the United States, Canada, Iceland, Ireland, Saudi Arabia, United Arab Emirates, and India. Went public at the end of 2020. And then I got a call from these 2 physicians who had been working on the problem of pre-engagement, or could we use healthcare technology to collect the patient's history before they saw their provider? And I thought, wow, super cool, a wide open space, and I dove right in. And here I am.
Great. So we want to dive into, for each of you, really your specific technology solutions and your thoughts. But I want to just kind of open it to the group. First of all, why do we even care about physician burnout? And what is the real impact? I mean, for most people, people aspire to become a doctor, and, people work hard to get into medical school. It's still a very fulfilling profession. So why are we even having this conversation? Anybody want to start?
I'll let the doctors start.
Sorry?
I said, I'll let the doctors start.
Okay. Good. I think maybe from our experience of being a physician by myself, but also then what we know from research and talking to physicians is one of the big impact, and that also increases then even the stress on physicians, is that errors occur if they have burnout. Yeah, and so the error rate in treating patients goes up significantly. We know that from research about burnout, and we also know from our own research in looking at treatment patterns of patients with atrial fibrillation, for example. We know that 40% of the patients are not treated correctly. And there are many reasons for it, but one of the reasons is physician burnout and overload, that they are not able to cope with the latest developments and guideline-directed therapies, that they're not able to consider all the comorbidities and co-medications that a patient has. And then they don't treat the patients the way they should be. And that leads then also to adverse patient outcomes. So while there is a direct impact of physician burnout on the physicians, obviously, there's also an indirect one, which is very significant for patients as well.
And we'll go to Chris next, and then Brianna.
Yeah, I mean, I would just echo that. There is a vast literature on the negative impacts of burnt out clinicians, from patient care to working with their teams. And not to mention, as a physician, being burned out is just bad for you. It's bad for you personally, it's bad for your family, it's bad for your kids. It's just bad from top to bottom. I don't think there's much controversy about that. And so there is a compelling case to address burnout effectively, I think.
And
Yeah.
Brianna.
I agree with all of that. I would add one other point, which is that physicians are smart people. And I think in a lot of care settings and environments right now, they're being pushed to a point where it's not as sustainable. Like, it's bad for them to be so burnt out. It's not a sustainable lifestyle, and they can go do other things. So just a slight bit of my perspective from this. I started off actually at a niche consulting firm helping burned out and like angry physicians leave healthcare systems and start their own practices. So I've kind of lived as a physician advocate trying to avoid burnout there, and then worked on that for a hospital system in the US. I'm in Denver, Colorado, and helping the hospital system try to use technology to prevent burnout, and then hopped over to Nuance Communications, which was acquired by Microsoft to help launch DAX, which was a early player in the ambient scribe category. So really a specific product with the goal of reducing clinician burnout. And as we're launching that across the US in different care settings, in the UK, in Canada, in France, it seems it's really sad to see how widespread clinician burnout, and especially physicians, that issue is, and also how much it impacts. While it's different in some of those different areas, we see higher retirement rates at younger ages in some. In others, we see really long wait times because clinicians can't see more patients. They have so much paperwork, or they're leaving clinical practice. So there's just a ton of no matter where you are, this is an issue, and it's impacting different communities in different ways. But it's bad for the physicians themselves. It's bad for the patients when they're actually sitting down getting care, and it's bad for patients when they can't access care because clinicians are leaving.
You know, when I talk to physicians about the role of technology, a lot of times it's with a lot of suspicions, like, please don't give me another technology solution here. In some ways, it feels like the technology was the origin of a lot of the stress with the advent of, you know, electronic health records and stuff that just added a tremendous amount of documentation burden. I think we would all agree that documentation is a good thing, but the process itself is just challenging, and it just created a lot of work. So I'd love to learn, with that in mind, I'd love to learn, and maybe we'll start with Brianna here, but I'd love to learn a little bit more the details about how you believe the technology can be a solution and not part of the problem.
Yeah. So I totally understand that viewpoint. You look at, I don't have like the latest numbers in front of me, but it's like a third to a half of physician time is spent documenting in most of the markets I look at. And that's really a tragedy. Nobody goes to med school and is like, yeah, I just want to fill out paperwork. They're here to help people, and that's should be a side task, and ends up being a lot of what they spend their day looking at and working on. So I totally understand that frustration, and I recognize that a lot of that has come from EHRs and the push towards them. So what we've seen, again, I've spent the last 5 years working on a ambient scribe solution that listens to the conversation between a doctor and patient and drafts that note. And we've seen really phenomenal results, both in the data and in the love stories. I ran the survey that we would get kind of feedback on the product for several years. And I got so many really nicely written letters about how you saved my marriage. I used to go to work and see patients all day, and then stay late and chart, and then come back, have dinner, and chart all night. And then I was just so exhausted that I had to like stay in bed all weekend. And now I can just review the notes at the end of the day or in between appointments, and I don't have to do that. So I don't think we're there yet. There's obviously a lot of tasks. There's orders and after visit summaries and all these different things that this technology specifically is expanding into, but we're still touching a relatively small part of what adds all of this load for physicians. So all that to say, we've seen really great growth and results, and I think we're heading in the right direction.
I'd love to go to Chris next because Chris, so Brianna's talking about ambient documentation. You have a different point of view, and it's a different part of the cycle of the documentation. So tell us a little bit more about First History and how that works.
Yeah, so First History solves a different part of the care process. There's before you see your provider, there's the time during, and then there's the time after. And we deal with the time before. So we've got an AI-based solution that conducts a comprehensive, thorough, precise medical interview before the patient sees their physician, so that when they walk through the door, their cardiologist already has all of their history of present illness, all of their past medical history, all of their meds, all of their allergies, all of their social determinants of health, functional status, if they're slightly older, all the risk scores and calculators, the questions have been asked, the scores have been calculated, and it's been presented for them in a clinically intelligent way so that they start much further ahead than the traditional model where a patient walks in, you're starting pretty much from scratch. So that's the idea. And the idea there behind First History is that it drives efficiency. It automates that which is routine so the physician can focus on that which is unique about each patient.
Great. And then Georg, tell us more about Tenaccio and how it is used for physician burnout.
So, so we are coming then in at the next step during treatment, and maybe just going one step back to how you started this round of the discussion, Pat. If you think about back, technology in the physician's offices was originally not invented and developed to help them, but to help the administration and finance departments. Yeah, and so that's why it made their life so miserable. It made the life on the administration side and reimbursement side easier, but that's why they hate it so much. Yeah, because it was not, and it is not there to help them. And this was then for us the starting point, and also my co-founder as a physician, a practicing physician himself, we said we really need to develop something that physicians love, and that where they say if they use it, it makes my life easier and faster, and I can be better in treating patients. And so we spend a lot of time on making sure that we have an intuitive user interface, yeah, because we know that nobody will see a video or even read a manual. Yeah, it needs to be so intuitive that even with the first patients, they know exactly what they need to do in order to get the desired outcome, which in our case is that we provide an individual risk for cardiovascular outcomes based on a proprietary algorithm, and we provide the physician with the treatment recommendations, what he or she should be doing in order to get the patient on guideline-directed therapy. And then we also simulate the impact on the risk that those recommendations have. And it's really then those 2, 3, 4 things that a physician should be doing. Obviously, the physician always has the final call and can decide whether he wants to follow it or not. But he knows if I do those 3 things, then I don't need to worry. I have considered everything. I know that this patient will be on guideline-directed therapy. So it makes it very fast, very easy, very actionable. So it's also, we don't give them a huge literature download of what things are saying, but we really, it's like 2, 3 sentences. Well, because of this risk for the patient, please do A or discontinue B. Yeah, they can always dive deep into. I think that's also an important aspect, that there is transparency, that it's not a black box and they don't know where this is coming from. They can always get to the AHA guideline and the verbatim where it is written, but they don't have to. They don't need to worry. And this was really the feedback that we got from physicians, that they say, well, I'm so much faster and easier, and I can really focus also on the more complex cases, and I don't need to worry that I have forgotten anything.
So it sounds like all 3 of your solutions really represent 3 different points in the care journey. Are these systems complementary? Are they redundant? Is is there more evidence for one versus the other? I'd love for you to maybe even, interact back and forth as far as, as far as these approaches.
I think
I
they are
would-
very complementary, actually. Yeah, and so I think it really because they address different aspects of the work that need to be done. And to be honest, I think that's also one of the challenges, that a lot of solutions are fragmented, if you will. And this is also some of the objections we get from a healthcare system point of view. They say, yeah, that is nice. We see the value of it, but it serves one problem of the 200 problems that we have. Yeah. And we would like to have a solution that at least addresses 100 problems because we cannot cope with 200 different things. Yeah. And I think that is, one of the challenges for us as providers. How do we connect things and work together, and then be maybe also able to offer a solution that offers a broader scope than each of us individually can do.
Yep.
Yeah, I
What
would
are
echo
questions?
that. I think our solutions are complementary. They happen at slightly different phases in the patient journey. We collect structured evidence-based data based on the AHA guidelines, obviously, and other sources of data as well too. And we do it consistently, and then we can feed it back down. Like for the scribe, if the question's not asked, the scribe can't hear it. I still have to ask the question. So why don't we take advantage of the pre-engagement space? I'll say I was just at the American Cardiology Conference in Chicago last weekend. I can say it's a good time to be a cardiologist because there is a huge shortage. There were all kinds of job opportunities there, and we're not making any more, and yet the demand is going up. And so how are we going to meet this capacity challenge? How are we going to meet this quality challenge? It's a multifaceted solution. There's not one solution that fixes all of it. And I think each of us has part of the solution, which is great and super impactful. Like, we improve efficiency 25%. We have a 95% patient engagement rate. They love it. They love it. They complete it. We provide real-time data at the point of care on practice patterns. And so that's highly engaging. But that's just pre-engagement. And then obviously you need what the scribe does, and then what your solution does post-engagement. I think and it's getting one thing I'd say also in terms of meeting the challenges. One of the things in the past in healthcare IT is that solutions have tended to be a bit fragmented and isolated and siloed. And I think it's getting solutions like ours to work together that will actually meet the entire challenge.
I agree. I think they're very complementary. I'm just going to use kind of an example. So a patient comes into a cardiologist to see a cardiologist, right? And they have all these things that they need to explain. So if you are using just an ambient solution, the doctor still has to ask all those questions, or the MA or somebody, and then the patient still has to answer. So yes, maybe we can take away from the cognitive load of them having to type the responses, or cut the time down that it takes to capture that information. And that's great, right? Doctors spend a ton of time just documenting. However, if we could shift that to getting that information from the patient ahead of time, like that helps that much more. Or even if you could get that data from previous visits or from when they've seen other caretakers. So all that is kind of a statement to, yes, there's layering and there's benefits where all of these are complementary. There maybe is some redundancy, right? And if you are getting that information ahead of time, my product adds slightly less value because that's conversation that doesn't happen in the room, but there's not complete overlap. And then also emphasizes the issue of fragmentation, of different solutions, of integrations between those. And I think more so, especially in the US, of data, where a lot of times physicians can only see data of this visit, this practice, this healthcare system, this EHR. And what AI does best is taking in massive amounts of data and being able to analyze it at a speed that humans just can't, one human can't do. So in a theoretical world, what I'm like most excited for, and we'll see in what areas this plays out first, is when AI can look at all of my lab results over time, or all of my wearable data, or my data compared to a large population of people who have the same symptoms as me and say this helped these people. And right now we're really on kind of the front edge of this, where we're looking at more specific use cases that are easier to tackle, where you can get data. A patient can enter data before they come in for a visit. We can listen to data from one appointment, but where I see AI having really transformational value in healthcare is when we can get to these larger data sets and being able to implement it there.
You've each mentioned in a slightly different way the value proposition, from efficiencies to quality improvement to even satisfaction. How are you measuring that your system is doing what you hope that it's doing, and how does that, and I'm assuming that it's primarily, related back to the quality of care. Do you also have any measures directly related to burnout or satisfaction? And why don't we start with Georg? We'll go around the other direction on the wheel here.
Yeah, to be honest, we are focusing more on the patient side. So we are looking at the number of patients who are being treated according to guidelines, and then we are also looking into patient outcomes like hospitalizations, strokes, premature death, where we haven't specifically looked at this physician workload aspect, but I think it may be an interesting point for us to do. Yeah.
And Chris?
So there's three people in the exam room, or three parties. There's the patient, there's the provider, physician, and then there's actually the healthcare organization. And so on the patient, patients get to rate our application and write comments. We have a 97% approval rating. One of our challenges, when people think intake, they think forms. I've yet to meet anybody who enjoys a good form fill. There is no such thing. Forms are miserable. So people immediately go there. First history is not a form. It's an adaptive application that the questions it asks are based on the previous answers, just like when you're conducting an interview yourself. And so it's completely different. And because it's not a form, patients love it. And because they love it, they complete it. We have completion rates of like 97%, which is off the charts. And so that's fantastic. And that's super important, because if they didn't like it and didn't complete it, then there'd be no data. The next step of the journey is the report that's generated from what the patients put into first history. And so we produce a report that is structured in a clear, concise way with all the relevant information that the clinician needs, that can be customized to meet local circumstances, meet specific areas of practice. So the history we would take for a general cardiology practice would be different than the history we take for a structural cardiology practice. So we can accommodate those variations. And because we get that right, then there's value to the clinician. And then the value to the organization is everything, really, because the data that's collected impacts anything pretty much you can think related to clinical care. It's diagnosis, it's treatment, it's prognosis, it's navigation, it's triage, it's charge capture. It's literally everything. And so different organizations will find different uses of the data, but it's got a huge value there. And so those are sort of our three main value props. I'll say on the provider side, we track that regularly, like we do mid-90s in terms of satisfaction there. And organizations, they vote with their feet. They're using us, they like it, and we follow that as well too. But I will say one last quick point, and this is true for all of the AI literature. More study is needed, and we do need rigorous studies, and we are, exactly, that's a whole topic into its own right, but I do think we're in the early innings on this, and I think the opportunities to study this in a rigorous way, I think there's so much opportunity here to be done, and that will help us refine it and make it better.
Brianna, I want to hear about the data capture part, but then I want to dive, and we'll start with you on that, is how AI seems like it's integrating every single aspect of our lives. So we'll get to that next. But Brianna, just tell us how the what kind of data you're capturing in your system.
Yeah, so data specifically on the impact that Dragon Ambient Experience, which is DAX, and then we just announced Dragon Copilot, which was going to GA in May. So the data that we're looking at there, if I'm going to start kind of small level and then go to more broad population size. So first of all, the organizations that are implementing this technology, especially the users, really want to understand that, right? Again, a lot of smart people, a lot of academics. So we have organizations that are implementing it, doing their own studies. If you just search for that, there's several that have been published in journals just even in the last month. So they're looking at all kinds of things from burnout rates, retention, and the ease to recruit physicians, because it is a big source of pain right now. They're looking at time savings, patient scores, documentation quality, reimbursement rates per encounter, throughput in number of encounters that people are seeing a day, all kinds of things like that. So those are just some of the metrics, and at individual organizations, they're pulling their own data together for that. At kind of a larger level, most EHRs have reporting around the efficiency of their end users. So there's some variability in what metrics exist within different EHRs and how those are calculated, but we're able to look at Epic has like very specific metrics, and Cerner has specific, Oracle Health has specific metrics for that. So we've been able to see some of those across healthcare systems. And then because of some of this data interoperability, the issues, the piece that we have across all of our users are some of the data points that we get back through our product usage. And then also we survey all of our end users, and at certain organizations that want us to help with this, we study their patients. And that's where we see, I have a lot of conversations with healthcare system execs, and they're often like, well, like that's like subjective. I don't really care what a doctor thinks. But at the same time, if we're trying to tackle burnout, what the doctor thinks is what should matter. So 70% of users report that they have better work-life balance and reduced burnout and fatigue after using our solution. So that's super exciting. 77% say that it improves documentation quality. We've done other studies looking at documentation standards, but there's so much variation in what looks like a good note that getting a doctor to say that something can do something better than them is hard. So 77% saying that documentation quality has improved is amazing. We have specific studies that have been published, but also here across different specialties, it varies, but really great results about providers saying, this is saving me so much time and cognitive load that I could see additional patients. And we hear about a 5-minute reduction in documentation time per appointment. And then also when we survey patients who are seen using this technology. So the doctor's using this technology, they don't have to sit there and type, they can look at the patient face to face, focus on providing more comprehensive care and really talking to them. 93% of patients say that their physician feels more personal and conversational. So all of us are patients at some point in our lives. Going in and feeling like you can connect with your doctor is huge.
Great. Chris, you mentioned the word of the day, AI. Seems to be impacting everybody's life in every single category of our life. So, and the latest round of interest in AI is really around generative AI. So how has that technology impacted either directly into your solution or just indirectly as part of the process?
So good question. Specifically with respect to First History is a blend of AI technologies. So we use generative ML, NLP, we use computational, algorithmic, or programmatic, and we combine them together to solve the extremely hard problem of how to take a history. And a history at first seems easy, but it's actually an insanely hard, like what questions you ask in what order for all the different diseases and symptoms and risk factors, and doing it in a way that actually meets the needs of the clinicians, that can be multilingual, and it goes on and on. So that's a hard problem. And just one tool, just generative AI or just, name your other technology is not going to do it. So I think a blend. I think that then takes on to the next question, which we want to think about how we want to talk about it. But obviously, generative AI is an enormous deal. I will say that as a clinician, one of the challenges you encounter, I would say 2 statements are true. Never has a technology held so much promise, and at the same time And never has there been so much hype and BS at the same time. And both of those statements are true. Like the people who say this is nothing are dead wrong. And then the people who say that this is infinite hyper exponential at the same time, I think, and so the challenge is finding what are the practical uses that I can, use and, that are actually going to help. And I think that can be challenging to sort out sometimes.
Georg, tell us about Tenaccio and how you're using AI or different forms?
Yeah. We also we have been using AI in developing our risk prediction algorithm. So we used big data analysis to identify the risk factors that drive the individual risk, so that we are really able to calculate the individual patient's risk and not just provide a broad category like Charles VAS, but really point it down to a decimal number. So that was a machine learning approach. We have been experimenting now a little bit with generative AI to develop our what we call recommendation engine. That has been pretty sobering to I must say right now, because it is just very difficult to get the large language models to produce really the correct answers. And then we need to have 100% correct answers. 90% is not good enough when it comes to treatment recommendations. So we're still working on it. We have now teamed up with a large tech company, and hopefully we'll be able to find a way to do this, because what we experience right now, what we have been doing is we have developed a module for atrial fibrillation. We have one for cardiovascular kidney metabolic diseases, but there are more, obviously, and the more you add, the more complex it gets, because the patients have all kinds of comorbidities. And at some stage, I think there is no other way than using generative AI to actually figure out what the optimal treatment is. But the path to that, I think it's still it's a way to go.
And Brianna, I'm assuming you're using AI in its different forms in your solutions as well?
Yeah, definitely. Like Chris, we're using kind of a blend of AI. And I also, like Georg, had a very sobering experience in jumping into that. So I came from a healthcare system that was using Dragon Medical One, which is often just called Dragon, and that's Nuance's dictation solution. And that is really, really good. It's been around for a long time. Like it's very consistent. And so I come in and they're launching this conversational AI product. And I was like, well, how hard could it be? Like they're so good at dictation already. What's the difference between listening to what a doctor wants to put in the note versus a conversation and just putting that in a note? And man, it's very different. I'll use the example of like a geriatric visit. You have let's say a man who comes in with his wife or his daughter, and you have a doctor in the room and an MA in the room, and the doctor is saying things, the MA is responding. There could be conversation, oh, like, I got your coffee. That's going on kind of in the side. There can be conversation where the patient says like, oh, I'm totally fine. And his daughter is like, no, like, remember last week this happened and you fell. And oh, we're going to Disney World next week. We're so excited. So there's just so many different pieces of conversation. So the AI to like necessary to know who's saying what, to decipher what's important and what actually belongs in the note, and then also to generate the note. So we're using different kinds of AI for all of those in this solution. So yes, but I think ambient scribing was probably one of the first like economically viable and largely visible use cases for generative AI specifically, because that technology was so expensive and doctors' time is really valuable. So it's been really fun to see the perception and reception from both doctors and the public change as we went from this has to be 100% all the time because I'm thinking about it as a human scribe or like dictation, to understanding more this is a tool to help with efficiency and give me a starting point. And I know that I'm using this tool as a physician and still need to check up on it, along with other evolution that we've seen in the last 5 years.
Great, thank you. So I can tell, I mean, you're adopters, you're excited about your technologies. Tell us a little bit about your concerns, the challenges, the barriers to adoption, and what you're doing to mitigate those. We'll start with Georg.
Yeah, I think one of the biggest obstacles that we are facing is a kind of a bit schizophrenic, that physicians are saying we are too busy to think about new innovative solutions, which are actually there to reduce their workload and make them less busy. Yeah. And but it's still sometimes very hard to convince them to even get into a discussion and conversation to show them how it can make their life easier going forward, because they block right from the start, saying, well, I'm too busy to even think about anything that could help me, which is, I think, yeah, a little bit schizophrenic and unfortunate. But that's, I think, one of the biggest challenges. Then it's, the integration with EHRs, that it's really seamless, that it works in the workflow, yeah, which our solution does, because it's integrated. And again, it must make their life easier. If it makes it more complicated, then you're dead right from the start. But convincing them that it really will work seamlessly and not increase their workload, I think is another one which we are addressing with the very intuitive user interface, and also the data that we have from and the feedback from other physicians saying, yes, it really helps me, and it makes my life easier and simpler. So from my experience, it's really the first step, or the first hurdle you need to take to get into a discussion. Then most of the other things can be solved, but really to get the time from them to consider an innovative solution is the biggest hurdle.
So how do you get them from a no to a yes? Do you have to let them try it? Do they need to see data? What's the formula there?
It's a mix of data. Yeah, so we have good outcome data, 50,000 patient in silico study, where we have shown that we can reduce mortality and stroke by more than 20%. So that checks then the clinical argument that there is that this is useful. So it's that's first, usually we come through the clinical side on the cardiologist, and this hurdle we can take quite easily. They also usually then, once they are engaged, they see that it makes their life easier, that they can also have like PAs and Ps looking after the pretty simple, straightforward patients, yeah, together with their tools, so that they as specialists can really focus on the more complicated ones. It gets more tricky then when it comes to the IT department, yeah, and the IT integration. Lots of obstacles there. Them just switching the EHR system from one to the other, merging healthcare systems, and then they need to merge the IT and don't have time for innovation. So the ones that have less benefit from the solution are usually the more difficult ones to convince.
Great. Brianna, what are your concerns and challenges, and what are you doing to mitigate those?
Yeah, I want to say ditto to everything that Georg
Exactly.
just said.
Yeah.
I will say, I mentioned how it's been really interesting. Like, the technology I'm working on has been out and publicly talked about pretty broadly for 5 years now. So we've seen a lot of evolution in um, kind of the concerns and the questions that people ask. So I think at the beginning it was a lot of, can we trust this? Is it going to be a good note? Where does the data go? Is it actually going to improve my workflow, prove to me that it will, integration questions, things like that. And I think those were the right concerns at the time. Like, the concept of AI, and especially generative AI, was really new. There was a lot of unknown, and some of that has driven, some of that was going to get resolved anyway. Some of that's driven our integration solutions and the workflow that we've built. And on the opposite end of the spectrum now, ambient scribing has become pretty well adopted. And most healthcare systems, at least in the US, have thought about it, have at least a couple physicians who have piloted it, have decided it makes sense at the current price point and functionality for these specialties or these care settings to use. And it's become this huge competitive landscape where there's now over 145, I think, companies that are offering something similar to this. There's very big differences in the offerings, but like, we were one of the only ones before, and the qualms were with the specific technology. And now It's how does your technology compare to this other offering, or where is your roadmap going, things like that. So seeing that as it's become a more mature product category, the objections or the questions or the concerns shift from our hospital users. And then also I mentioned we're expanding internationally, so it feels like we're kind of like hopping back in the questions that we're getting again, partially due to it's just not an adopted technology in some of these countries and places, and also due to regulation.
And Chris, I'll just assume that there may be some dittos here. Feel free to expand upon that, but really, what are the barriers to adoption? Again, how are you getting from a no to a yes for some of these groups?
So absolutely ditto on all fronts. I would say that the challenges that Microsoft faces going to market, that myself and Georg face, are slightly different, just given organizational size and everything. The key thing for us, and this is a challenge of doing something new in healthcare, because healthcare is conservative, as you say, they've got all these things, is they've got to see it. So we can provide real-time data at the point of care on everything that's being asked for in our questions. We can provide data on adherence to guideline-directed medical therapy. But saying that, a lot of people, yeah, I've heard like 10 things today already. So they see it really is seeing is believing, that you have to connect with the people on an individual level to get that message out, and then to build the community. And then the other thing is peer proof. So if your peers are using it and they like it and they talk to their peers, then that will drive growth. And that is the core of how we get the word out about this, fundamentally new approach to the care process. And, the good news is that it actually works. And that, when you do show it to people, that's good. But, it does take time to meet everybody and get the word out.
Yeah, maybe just to Chris's point, I think that's also an experience that we have, that we also use in our tool, actually, for exactly the same reason, that we give the individual risk of the patient, because we know if the patient knows his stroke risk is like 5.3% and he can reduce it to 3.5 if he follows the therapy, that is much more impactful than telling them about a general huge study that has been done where they can't really relate to. And so what we also do with healthcare systems is we offer them actually to do a simulation where we say, well, if you give us your data of your current patient population, the current treatment, then we can tell you by how much you can reduce outcome events and by how much you can reduce costs for your healthcare system. And that usually then makes a quite convincing argument also from the business side.
We do have a question from the audience. So how can healthcare organizations ensure that implementation of these new technologies reduces rather than adds to physicians' administrative burden and cognitive load? Anybody want to take that?
I can start with mine because it's easier, probably. So our solution's like totally elective. So a healthcare system can say we want these many licenses, and if a doctor doesn't like it, they don't have to use it. So that allows us, I think that's a huge difference between ambient scribing as it's coming to market and EHRs, where at an EHR, the hospital executives said, yes, we're going to this EHR, and like you as a doctor are going to do so too. And so doctors got kind of forced into workflows that maybe they didn't like. And in the ambient scribing world, there's no pressure for clinicians to use it. So they're only going to use it if it is providing a better experience for them. And that means that we can use adoption. We have to look at adoption data differently because it's not like an EHR where they have to use it, but it makes that a very good kind of proxy to measure, is it adding value and data point as we look at our roadmap or as we make changes.
Excellent.
And I guess I would just say for us, physician founded, physician led, obsessed with the things that physicians care about, which are, efficiency and quality. And once again, you don't have to use it if you don't want to, but taking a history, I just say to everybody in the audience, like, it takes time. And doing it well is hard, and you've got an office and you're going to see 40 people. So wouldn't it be nice if you had an application? So it just kind of makes intuitive sense that this thing would save time. And you can tell immediately, this isn't something that you need weeks to see the results of. You'll know within the first half day that this thing actually helps. And that's been our experience of it.
I think for us, the experience is that sometimes a little bit ambivalent because the executives usually they don't want or they want to make it mandatory because once we presented the ROI and then the head of cardiology usually says, well, I really want to make sure that all of my physicians are treating the patients according to guideline-directed therapy because I believe that's the right thing. And I see a lot of diversity in how patients are being treated, and I would like to streamline that. So they definitely want to make sure that all the physicians are using the tool once they decided for it. But we usually then also say, well, let's do first phase with a pilot where physicians can opt in, yeah, to really get the buy-in and to get engagement of the ones that are more open, yeah. And then once they have the positive experience, then they can share it with the others, and then you can get others on board that are more critical.
So we're going to really wrap this with really what does the future look like? You know, we know this is a dynamic technology. It's moving fast. So why don't we start with Georg? What does the future look like in this space? You know, what's next? And, you know, are there any breakthroughs coming that you're able to share with us?
Yeah, I truly believe that AI will make a huge difference and that also generative AI will get there eventually to really be a super helpful tool in diagnosing and treating patients. And I think in the not too distant future, it will be seen as like irresponsible if you don't use a support tool in your daily treatment of physicians. And I think physicians will want to do that. Patients will demand it. Probably also payers will demand it. So I think this will certainly where things will be going. And I think the great thing is that it helps everybody. It's a win-win-win situation, yeah, because it will help physicians to reduce their workload and their burnout rate. It will increase their work satisfaction, also with the impact on their families, as Chris mentioned at the beginning of the conversation. It also helps patients to avoid adverse outcome events, and it helps healthcare systems reducing costs and managing costs by making sure that patients get the right treatment and therefore avoid hospitalizations and really very costly events. So I think, yeah, I think the future is really great. There are great prospects, and it will be very beneficial. But it's still a way to go where we need to overcome some hurdles.
And Chris?
Well, obviously I'm here. Obviously, I think AI is a great thing, or I wouldn't be here. However, I would say that we're at an interesting juncture because I don't think it's a given that it's going to be a utopia. I think there's dystopic scenarios as well, too. You know, if AI is just used to drive people to see more patients, to bill more, it just focuses on, you know, we can think of a dystopian future where, you know, things are not good for clinicians. It could actually make things worse, and it doesn't require a lot of creativity to see how that could be the case. At the same time, I've been doing this gig for a while. I've been in clinical practice. I've never been at a more exciting time in clinical medicine when there is more opportunity to do more creative things. And so I am very optimistic ultimately. I think the key will be, I mean, there's multiple keys to this, but one of the key things is physician in the loop, physician engagement, engage around the medical knowledge and the medical practice. We don't want to outsource that just to AI in quotation marks, but we want to work with, because they're not large knowing machines. They're large language models, and all they can do is hope to point at the authoritative source of truth. One of those we're on this webinar with, which is the American Heart Association. So we want to use AI to empower that, to empower the clinicians to apply the knowledge, to apply their clinical experience. And I think if it's done that way, and then we do it in a way that actually saves people time, that's critical. And I think the tools can. I mean, all three solutions here save people time, can improve quality, improve patient engagement. And so I think there is a huge opportunity to get it right. So I think the key to that is the clinical engagement, because I don't think it's a foregone conclusion. I mean, we're going to have to pay attention to it and try to get this right.
And Brianna, we're going to give you the last word.
Oh, thanks. I think specifically within the ambient scribing space, the breakthroughs have already happened, right? It's the technology has progressed enough that there's demand. Providers want to use it often, and if they don't want to, that's fine. They don't have to. I think that what it looks like going forward is really progressing capabilities and who has access for it. Right now, that's heavily limited by where you are, both in care setting and in geographically, things like that, and the ability to afford it. So I think that that'll be kind of the biggest change in ambient scribing in the next couple of years, is hopefully getting to a point where any provider who wants to use it can use it. And then I already kind of talked about my long-term thoughts for AI, but getting to a point where all of this data can be used in a meaningful way and AI can help do that efficiently.
Great. Well, I want to thank all of our panelists for an amazing conversation about a very important and relevant topic. This session is recorded, so it'll live on into the future on our AHA YouTube channel, along with the previous webinars that we've done. Our next webinar is going to be on May 7th, and it's on expanding access, leveraging health technology in rural communities. So, so we're looking forward to that topic. But again, I want to thank all of you for your participation, and have a great day.
Thanks all.
Thank you.
Thanks for having me. Thank you. Bye-bye.